So in this video I wanted to explore some top tips for renal. So a mnemonic for hematuria that I like is SIT with 3 T's, and this can stand for stone, infection, trauma, tumour, or TB. And you can see that TB, tumour, trauma and stone can all be obstructive causes. So that's why, as part of our AKI checklist, the A, B, C, D, E that we explore in another video, the E was to be exclude obstruction, and infection can be the other side. It can irritate all the pathways and cause hematuria. So that's why dipstick is your best test, or more importantly, urinalysis is your best initial test. Urinalysis will show things like hypertension and DM via microalbuminuria, which can also be present if the patient's on an ACE inhibitor or an angiotensin receptor blocker. Another indolent cause of microalbuminuria is the fact that if you're working on your feet all day, you're running around, you do a very hefty job, you can have signs of microalbuminuria as well. You get increased protein in the urine. Another important thing to say would be nitrites. So don't say nitrates, nitrites. Nitrites. If they're present in the urine, bacteria, particularly gram-negative bacteria such as E. coli, so gram-negative bacteria like E. coli, eat nitrates and give nitrites. So if you get nitrites, they're likely to have something like a gram-negative E. coli infection in their urine. But we also look for white blood cells within it, so white cell count might also show infection as well. So both nitrites and white cell in a dipstick will show infection. Other important things that can be seen in urinalysis can be eosinophils, bacteria, hyaline, red cells and broad waxy casts, along with granular cells and white cells. Eosinophils can be a sign of allergic interstitial nephritis, or AIM. Bacteria, I suppose this can be indicative of a urinary tract infection, and if there's no white cells, it can be normal, and in pregnancy you should be beware, because about 30% can go on to get pyelonephritis, so it can be infective. We'll see those. Hyaline casts can be normal, but can mean you're dehydrated. Red cells can be a sign of glomerulonephritis. Broad waxy casts are a sign of chronic renal failure. Granular cells from the accumulation of epithelial cells can be a sign of acute tubular necrosis. And white cells can either be those things like pyelonephritis or an interstitial nephritis. So it's interstitial nephritis. For something you must remember, it is the absolute indications for dialysis. So this is the AEIOU way of remembering it, and these are absolute contraindications where conventional treatment is refractory, i.e. it's not working very well or is only having a modest effect, and these conditions are getting worse. So all of these are, when refractory, acidosis. So a refractory acidosis, where the therapies that you're giving them to treat acidosis is not working. They have electrolyte abnormalities, such as a hyperkalemia. That's important, where it is not responsive to medical therapy, such as insulin dextrose treatment. Intoxicants, like aspirin, if you're not able to diurese them out, for example, and they're getting worse with a worsening acidosis. So intoxicants to actually remove that. Lithium toxicity, for example, if you can't get rid of the lithium. Overload, as in a hypervolemic state, can be seen in people whose kidneys aren't working. They can be overloaded due to hepatorenal syndromes. It can be overloaded due to heart failure, for example. The last U is uremia. And that's whenever you get refractory uremia, not responsive to any other treatment. and that can cause pericarditis, because if you think about it, would your heart like to be bathed in urine? No, it wouldn't. So you get a bit of inflammatory response around the heart. It can also be a cause of sepsis, AKI, and it can also cause bleeding. Uremia can cause bleeding because urea inactivates white cells, so white cells can't work in the presence of high uremia, so you're more likely to get infections, and also your clotting factors can't work properly in the presence of high urea, so you get bleeding problems, and it can be secondary to something like an AKI. Diuretics, we'll go over in another video, but diuretics can increase serum glucose, and they can also cause an increase in bicarbonate in the blood, and they can cause acute arthritis or arthritis. You should always query gout in loop and thiazide diuretics as well. These are common exam theme questions. So SIADH stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. This occurs whenever excess levels of ADH, or antidiuretic hormone, also known as vasopressin or arginine vasopressin. They are hormones that help the body and the kidneys conserve the correct amount of water. So antidiuretic hormone obviously stops you diuresing or losing water through the kidneys. The syndrome that we describe here, SIADH, causes the body to retain water and certain levels of electrolytes in the blood to fall, such as sodium. So SIADH is the concerning part of it is that you lose sodium. SIADH is rare in children, so it's more common in adults, and that's why you must remember that it's primarily an adult disease. The causes of it can be multiple, so infection, tumours, you can have meningitis, encephalitis, brain tumours, psychosis, lung disease, head trauma, HIV, hereditary causes, thyroid deficiencies, parathyroid deficiencies, all these things contribute to it. I'm not talking about that now, but what I want to say is about exam questions that ask about ADH is when is it not SIADH? And if they are grossly edematous, so not if, grossly edematous, not if they're hypotensive. These are all very relative, by the way. These are just for exam questions, so this maybe isn't something I want to take to clinical practice, but it's just to differentiate in exam questions. So usually not if they're hypotensive, not if they're grossly edematous, or like have ascites or something like that. Not if they have Addison's, because obviously that would give you a more information to diagnose Amazon, and not if they are hypovolemic. So let's just go over that again. The syndrome of inappropriate ADH secretion is defined as hyponatremia and hypoosmolality. So hyponatremia and hypoosmolality, and you must be aware that it is that the symptoms of a low sodium are from excess water rather than a sodium deficiency. Because you lose sodium, sodium cannot, therefore, whenever you're depleted of it, carry the same amount of water out of your kidneys, and that's a way to look at it. And when you're on a lot of fluids, you should consider the possibility of SIADH. Whenever you're giving lots of fluids, consider the possibility of SIADH, which will lead to water retention and fluid overload. So quick fire, give me the signs of nephritis. So if the examiner asks you that, what are the signs of nephritis? How about you diagnose nephritis without doing anything else apart from sort of doing very simple investigations? And the way to identify it is if they have hematuria, nephritis. If they have proteinuria, nephritis. If they have edema, they can have nephritis. And if they're hypertensive, they can have nephritis. So we're going to talk, yes, it's the renal bit, we're going to talk about diabetes and hypertension in the presence of kidney disease. These are massive causes of having to go on dialysis. If you are hypertensive and diabetic, you go on dialysis because you get microvascular complications at the renal level. So the other thing you need to consider here is glomerulonephritis, which basically, the longer you have essentially both diabetes and hypertension, the increased, the larger the risk is that you have glomerulonephritis and will end up on dialysis. And once again, as you know, the urine dip would be positive for protein. So actually, the earlier you can treat this with an ACE inhibitor or an angiotensin receptor blocker, because yes, they can cause renal damage whenever you're causing hypotension, but you want to treat the hypertension here, and whenever you use them appropriately and there's no signs of renal artery stenosis, etc., ACE inhibitors and angiotensin receptor blockers can be renoprotective, can be nephroprotective in this case, and you're aiming for a blood pressure below 130/80. So treat the hypertension, and then you treat the diabetes. That's very important as well, and you treat the diabetes by conventional means, and doing this early will prevent the risk of going on dialysis. So I've left a gap here for a reason. So we've already talked about nephritis. So if I asked you what the signs of nephritis are again, you would be able to tell me, right? So the answer is hematuria, proteinuria, edema, and hypertension. But what if they ask you to compare against nephritis and nephrotic syndrome? So a nephritic syndrome and nephrotic syndrome. So once again, we know hematuria, proteinuria, edema, and hypertension, along with uremia and red blood cell casts, would predominate the symptoms of nephritis or nephritic syndrome. So with nephrotic syndrome, you would see a urine protein count of greater than 3 grams in 24 hours. They'd be edematous, and they would have hypoalbuminemia, so they would low albumin content in their blood. So a pretty dire state of affairs as if your albumin goes below 20, and low albumin is very problematic, because albumin contributes drastically to your oncotic pressures within your blood. It's made by the liver, and whenever it starts to go down, you start to lose control over where fluid goes in your body, and this is why you get signs of fluid overload, where the fluid is spilling onto your lungs and giving you ascites, etc. You can also see hyperlipidemia within these patients, so increased lipid count. So what are you going to do with them? You're going to try to put them on an ACE inhibitor, which will decrease the proteinuria because it dilates the efferent renal arteries. You're going to restrict salt. So we're going to restrict salt intake more than their fluid intake. Because they have a low IgG level, immunoglobulin G, they are at a risk of infection. So you might want to monitor them for infection and give them appropriate antibiotics. 10% of these people get renal vein thrombosis. Children have a better prognosis than adults, so children tend to fare better than adults, but you tend to, in general, adults have an increased risk of venothromboembolism, so venous thromboembolic events. So let's move on to talking about dialysis now, and particularly the problems associated with long-term dialysis and the problem with dialysis in general. This gets asked a lot in finals. Some of the main things is you get anemia because you get decreased EPO, and this is all to do with the condition of chronic kidney disease, chronic renal failure, and the problems of renal osteodystrophy as well. So you get an anemia through decreased EPO, erythropoietin. You get decreased calcium levels and decreased phosphate levels in the blood because there's a vitamin D loss in general in your body, because there's impaired GI absorption of vitamin D that is then processed by the kidneys. So far, these aren't really dialysis problems, they're more to do with chronic kidney disease. However, once these sort of tend to happen, the decreased calcium, the decreased phosphate, you tend to have increased levels of parathyroid hormone that mobilizes calcium and phosphate in the body from the bones. This is how you get renal osteodystrophy. So what do? You can give bicarbonate, give calcium carbonate, pardon me, if your phosphate is increased. And that might stop the calcium being released. Just make it a bit clearer there. And something else that's coming out of literature is don't use aluminium based binders with dialysis to bind toxins. Binders, because they can cause dementia. So dementia can be a sequelae of aluminium based binders in dialysis. Some of the sequelae of peritoneal dialysis might be peritonitis or Staph aureus infection. Staph aureus lives in the skin, and because you have got lines going in through the skin into your peritoneum, you can get Staph aureus infections and cause peritonitis, which is not nice. Some of the other things you can get with chronic dialysis or dialysis in general, you get an increased magnesium level, so you just decrease this in diet. If you, for some reason, this doesn't happen in real life, but if you were to get a malignantly high magnesium level, you could give intravenous calcium, because calcium is the opposite of magnesium in the body and is used to treat profound hypermagnesemia, in the same way that magnesium can be used in some ways to help with calcium imbalances in the body. But this isn't really to do with what we're talking about. It's just worth knowing that magnesium tends to be considered the opposite ion to calcium in the body. So people on dialysis tend to have hypertension, and they can get atherosclerosis, leading to myocardial infarction, which is the most common cause of death. So your BP goal on those in dialysis is 130/80 or thereabouts. Infection on dialysis is important to realise, because these patients, not as a sequelae necessarily of the dialysis itself, but it can be introduced via lines, via dirty machines or human error, for example. But whenever you have a high level of urea, so hyperuremia in the body, it inhibits degranulation of white blood cells, so it stops them working, so that you are more at risk of infection. It also increases your bleeding risk. So these are things with chronic kidney disease rather than the actual dialysis, but it's usually by virtue of the fact that the person's on dialysis, they have such bad kidney disease that they are at risk of having hyperuremia, which causes the increased risk of infection. And the bleeding risk of CKD you would treat with desmopressin, which is the same principle as von Willebrand factor deficiency treatment. Some of the sequelae here of long-term dialysis could be carpal tunnel, rotator cuff pain, arthropathies, and pericardial involvement from the uremia irritating the pericardial lining, or myocardial involvement indeed. And prednisolone can reduce joint pain in these patients. Also, sequelae of dialysis is beta-2 microglobulin amyloidosis that can cause deposits in organs and therefore mess up the function, the baseline function of those organs. And if you recall, we said don't use aluminium-based binders in the same way we do use polyacrylonitrate, so polyacrylonitrate membranes in dialysis, and that's probably just a wee bit superfluous information, but it's useful to know what sort of membranes we use dialyze somebody. Pseudohyponatremia comes up infrequently in exams, but it's important to realise that this happens in essentially via increased levels of glucose in the blood. So if you have increased levels of glucose in the blood, as I've tried to label here, you will have a very hyperosmolar picture within your blood vessels. So we know that whenever you have a membrane here, say for example your artery or your veins have a membrane here, and that is selective towards water. So if you have all these things held intravascularly, such as sodium, essentially they're fixed intravascularly, sodium, glucose, you get a very sort of you get a liquid with a high osmotic potential. Water will follow those molecules. So what you have is water going in to the veins or to the arteries, and that basically causes a dilution effect, which leads to the appearance of a pseudo, so a fake hyponatremia. And it's fake because it's actually just it basically just dilutes the concentration in there, so you still have the same amount of sodium, but it looks like it's S because it is diluted. So try to remember what I said about nephrotic syndrome. We talked about a protein loss. Can you remember what that is now? A couple of slides later, what is the total amount of protein loss per day? It's 3.5 grams per day of protein loss in the urine. And if we correspond this to what does the liver produce? What does the liver produce per day? Liver produces albumin in the body. So what do you think it might produce per day? The answer is, unsurprisingly, 3.5 grams per day. So that's why if you lose 3.5 grams per day, you will get nephrotic syndrome, because you will get hypoproteinemia. Hypoproteinemia, and this will lead to lower oncotic pressures in your blood, and you will get edema. So that's actually, if you're losing that would be called hyperproteinuria. Proteinuria, and this is hyperproteinemia in the blood. So less protein in the blood, more in the urine, because you're getting rid of it. So you're getting edema because you have low oncotic pressures in your blood. And on all this talk about oncotic pressures, etc., the most important thing to realise about sodium in the body, sodium is osmolality. Which means that if you do have a decreased sodium, so if you have a decreased sodium, you will have in your blood. If you decrease sodium in your blood, you will have a decreased blood osmolality. And in the same way as if you've got a low amount of sodium in your urine, you will have a low urinary osmolality. But if you've got a high sodium in your blood, and you have got then a high osmolality in your blood. And that's very important whenever you're thinking about how water moves in the body. So if you have a high osmotic potential from having a lot of sodium, you will draw water in, so water moves in. And in the same way, a low blood osmolality means water moves out of your blood vessel. Do not correct sodium too quickly, it melts your pons. It causes cerebellopontine demyelination when you rapidly replace sodium. The serum sodium should generally be corrected at a rate that does not exceed 8 millimoles per day. So for example, if you have a level of 120 for sodium, you would want it within 24 hours to be no more than 128. In extreme cases, you should give your bolus of hypertonic saline as per your local hospital guidelines. I'm not going to mention them now because you're going to need to look them up, because they change all the time, and it's a very sensitive bit of medicine, given a lot of deaths that happen in the UK. So you will all have guidelines on how to use hypotonic saline in profound cases of hyponatremia where there is seizure, for example. So if you have a case where the person has a sodium of 120, you would not want it to be more than 128 in the first 24 hours. Should not exceed that. So we generally aim for a replacement at 0.5 per hour, 0.5 millimoles per hour. So that would be going 120.5 up to 121. That would be the first hour, second hour. That's the ideal rate of replacement per hour. So that's 0.5 millimoles per hour replacement. Correction of the value, that is not the amount of saline you give. You're going to need to consult your local policies for that as to what they recommend you give. But if you go to the website propathology.com and you look at the resource section, there is an IV fluid protocol algorithm that we wrote for International Fluid Academy, so you can find that out there. But in 8 to 10 millimoles per day correction, and that means bringing sort of your sodium from 120 to 128 or 130 in a 24-hour period. You want to do it slowly because it can cause cerebellopontine demyelination, which can therefore cause ataxia, brainstem injury, etc., etc. So it's not good. We do not like cerebellopontine demyelination, and we correct sodium slowly. So slow correction. But we'll do more of this in any videos we do on endocrine. But this is just as part of our talk about osmolalities and the shift of water with sodium and albumin and things like that. I just thought it would be pertinent to put it in here. But that is really it for the top tips, top facts within renal medicine. Join us for our other videos.